welcome. Thank you so much for joining us at this very special Cayman Connection Virtual Yard meeting. We are really delighted here to have our special guest, Dr. Mark Parmalall, with us. Mark is going to talk about his experience as a clinical neuropsychologist, a really fantastic and quite specialized role for a Caymanian or anyone to have. Really happy to have him on to talk about his experience. We will follow with some questions and answers. I will just take the opportunity to tell you a little bit about Cayman Connection before we begin. Some of you, I think, know, we've got some members here of Cayman Connection. Cayman Connection is a global network for Caymanians. We have memberships in the UK, the US, Canada, and we are expanding further afield. So please do let your friends and family know about Cayman Connection. We host a number of different events. We bring on Caymanians to talk about the fantastic things that they're doing around the world. And we also provide a support network for Caymanians who are far from home. And obviously that has been necessary, particularly in the last 16 months. We've provided these virtual yard meetings every week on Wednesday without fail. Some of our meetings are general chats, get-togethers, let us know your situation, your problems, your joys, have a chat and feel a little bit close to home when you're far away. And we also have some more formal events where we bring special speakers on to speak to us about their experiences and offer the opportunity to talk to them and ask questions and learn a bit more. We also have networking events where we specialize in growing your network and working out how this network can help you and how the people on our membership can help you. So really pleased to see you all. Please do sign up if you haven't already, caymanconnection.org/sign up. It's very clear on the website if you want to see what all the member benefits are and what you might be able to get involved with. So please do sign up if you're not already. And it is a pleasure to see you all. Thank you for coming. Welcome. We've got some new members coming in. Hi, Tom. Hi, Tony. Hello, Melanie, Hazel. Lovely to see you. So, to our Dr. Mark Parmalall. Dr. Mark Parmalall is a consultant neuropsychiatrist working in tertiary level unit, specializing in brain injury. His training in psychiatry has been entirely in the London Deanery, core training in the North East London and East London NHS Foundation Trusts, and higher speciality training in the Maudsley and South London NHS Trust. In this capacity, he is trained at the Institute of Psychiatry, Vlechen Royal, Maudsley Hospitals, and with the National Hospital for Neurology and Neurosurgery. These are the premier research and training institutions for psychiatry and neurology, respectively, in Europe. He's worked in national clinics for neurodevelopmental disorders, including autistic spectrum disorders, attention deficit hyperactivity disorder, and Tourette's. Not only this, but Dr. Parmalall was an honorary clinical lecturer at the undergraduate and graduate level, respectively, and was an examiner for both professional examination and academic postgraduate programs. Dr. Parmalall has also completed his core medical training, London Deanery, and he also holds a degree in microbiology and immunology. He has presented work at various international and national conferences and has contributed to a textbook and peer-reviewed papers, which are now in publication. So it is a real honor to have you here, Dr. Parmalall. Thank you for joining us. And we look forward to hearing a little bit more about your story and asking you some questions. Thank you, over to you.
Thanks, Kate. I think I am very unsure who the person you were just describing is. I think I've been very fortunate to be awarded some of these, posts to get into some of these institutions and work with some of the people that I have managed to work with, and I think it's through their encouragement that I have managed to achieve what I have, and the encouragement of family and friends as well. So I think very little of that could be me, to be fair. In preparation for this, was sort of looking back on my computer, and sort of took myself back to last year when all of this was happening. And one of my colleagues at UCLH had suggested that we look at the data coming out of China, and at that time, Italy had just started with their wave. And we started to look at the information that was out there. And last night it was sort of a trip back memory lane. We started a paper and another group sort of beat us to the punch. But it was useful to see how much information is now in the public realm and how much information we have about this virus compared to what was known a year ago. So why is it important to talk about COVID and mental health? Because that's predominantly what I'd like to focus on today. It's because, as Paul Former, who's the chief executive of Mind, said, the coronavirus pandemic is as much a mental health emergency as it is a physical one. The devastating loss of life, the impact of lockdowns, the inevitable recession that lies ahead will leave a lasting scar on our nation's mental health. And I mean, it seems a little bit as if this is something we should expect. You know, it seems a little bit of common sense, really. You know, we've had lockdowns, we have had people losing their jobs, we've had, you know, people not having the sort of structure in their life that they're used to. But does this actually, you know, get borne out in the numbers? Well, in the UK, children under the age, or people under the age of 18 are seen in a division of mental health services called Child and Adolescent Mental Health Services. One of the surveys that they looked at showed that the referrals for child and mental health services from last year to this year had gone up by about 22%. And this includes a wide range of problems that people got referred for. So things like self-harm, so it had an increase in self-harming episodes, disordered eating habits. So that's a nice way of saying people might have had things like anorexia and bulimia, or panic attacks about, you know, even going back into school when we had the first lockdown being lifted and children were allowed to go back in. It was forecast that about 1.5 million children require mental health treatment as a direct result of the pandemic. And there's concerns that the demand would outstrip the supply threefold. I'm sure all of you in the UK might be aware that we already have a shortage of mental health beds. It's no secret that sometimes children in the past have been, when they have gone into hospital under section, have been sent as far away as places as in the just basically south of Scotland. Some people have been even sent to Wales from London when there is no beds. So we already are in very low or shallow waters with low reserves, and something like the pandemic happening has just made it more obvious. The Royal College of Psychiatrists, which is my college, looked at NHS digital data, and they found that while the crisis affects people of all ages, under 18s were the group that suffered the most. They looked at the data between April 2020 and December 2020, and they thought that 80,000 more children and young people were referred into services. That's a 28% increase from the previous year. So what have we been able to do to sort of help with that? Well, 600,000 extra treatment sessions were put in offer. That's only a rise of 20%. So compared to 2019, the college estimates about 18 to 19,000 more children and young people needed urgent emergency crisis care. And this, as I said, is really, of concern, because there are very serious illnesses there, such as anorexia and eating disorders, that are included in that group. And that number also includes emergency care where people have to be considered for sectioning, which is the care for patients under the Mental Health Act, where they are admitted into hospital involuntary. Well, is it only children that are affected? Well, Mind, which is a very popular, a well-known charity group advocating for mental health services in the country, surveyed 16,000 people in the UK during the lockdown. They thought 65% of the adult participants with pre-existing mental health problems said it had become worse during lockdown, and 75% of those aged 13 to 24 reported the same. Of adults with no previous mental health experience, well, 1 in 5, or closer to 22%, said now that their mental health is poor or very poor. And Mind and the Centre of Mental Health predict that about 500,000 more people in the UK will need mental health support as a result of the pandemic. So you will say, yes, this looks like a very small number that Mind surveyed. Surely, that's a very skewed thing because the numbers are low. Well, a group from the University of Oxford examined the health records of more than 230,000 patients, sorry. A third of COVID survivors go on to suffer mental health and neurological conditions within 6 months. 17% had a diagnosis of anxiety and 14% had a diagnosis of other mood disorders. Now, the neurological and psychiatric diagnosis seemingly is worse depending on how badly affected by COVID you were. So if you were in intensive care, it came up to 46% of those people responding to the survey having a neurological or psychiatric diagnosis, and that number went up to 62% if you had encephalopathy. Now, is there anything that seemingly makes it worse? Well, looking at the data, you can see that 52% of people who lived in social housing said their mental health was poor or very poor, and that 2/3 of that group said that their mental health had actually gotten worse during lockdown. It's no surprising then that, when I mentioned that free school, the group of people who would fall in the lower tax bracket, enabling them to get free school meals, were also disproportionately affected, where they would say that their mental health was poor or very poor. 58% of those people surveyed in that group gave that response, as compared to 41% not receiving school meals. The group that's furloughed, lost their jobs, or changed jobs in the pandemic also had greater mental health declines than those whose employment status had remained the same. So it's very clear that your socioeconomic factors, your social inequalities, so to speak, are major determinants, apart from your how badly you might have been affected by COVID in terms of should you have gotten ill with it. So if you kind of think of the risk factors, females, those living in social housing, those people from ethnic minorities and frontline workers. What I thought was particularly surprising in the data when I looked at it was the disproportionate number of people who were suffering from a disability, be it physical or mental health disability, such as intellectual disability. They also reported higher rates of worsening in their mental health during the pandemic. So you could say, well, maybe this is a UK thing. Does it happen in any of the first world countries? Well, this is a question that was looked at in an article in The Lancet by Wang et al. And what they did is they asked the question, did COVID-19 infection affect mortality in the United States of people with mental health disorders? And they looked at the digital records. Hello? Hello? They looked at the digital health records, about 61 million adult patients from 360 hospitals across 50 states in the US. And what they looked at were to see if people who had a mental health diagnosis in the previous year, including things like ADHD, bipolar affective disorder, depression, or schizophrenia, had increased risk of getting COVID-19, were they increased risk of being affected by COVID-19, or was their morbidity or mortality higher? So patients with a recent diagnosis of mental disorder had significant risk of COVID-19 infection. The risk was disproportionately higher for those people who had a diagnosis of depression in the past. They found that African Americans had a higher odds of COVID-19 infection rates than Caucasian Americans. Women with mental disorders had a higher odds of COVID-19 infection rates than males. And a recent diagnosis of having a mental disorder with COVID-19 made you more likely to suffer death. So there was a death rate of 8.5% versus 4.7%. Or hospitalization. The hospitalization rate was 27%, and in non-mental health patients or non-mental health diagnoses, around 18%. So the World Health Organization said, well, why don't we look at this in other groups? So what did we find? Well, there was a study done by a US nonprofit, and they looked at people in 8 English-speaking countries across a range of socioeconomic groups, so higher income countries and lower middle income countries. And they surveyed about 49,000 people. And they looked at people, as I said, throughout different socioeconomic groups, but also different cultural backgrounds. So they looked at South Africa, India, Singapore among the group. And then they thought, well, how do we standardize this? So they used something called the mental health quotient. And that basically looked at 6 domains, so mood and outlook, social drive, drive and motivation, core cognition, complex cognition, mind-body connection, and they sort of quantified it by giving it a number. And what they found is that the overall well-being of 18 to 24-year-olds, when they looked at this being done in 2019 as compared to 2020, had dropped about 44 points, or about 15%. And so the most common thing that people reported from the study was apparently low mood and anxiety. So what are the effects of COVID-19 and your mental health, apart from these things that we've already looked at? Well, one of the things that probably comes to mind is, does it affect suicide rates? So in the early months of COVID-19 pandemic, between April 1st and July 31st, data was collected. And this was published in the Lancet Psychiatry, and they looked at rates of suicide, and they thought that rates of suicide did not increase relative to what was being modeled. And the estimates of number of suicide that would have occurred during this period without the pandemic. But that actually was not that surprising, because this is consistent with the observation that in national crises, people sort of pull together, and that could be a protective effect against suicide. And perhaps, the social cohesion that we might otherwise lack, and which is a protective factor, comes into play and might decrease the suicide rates. But we know that suicides can increase following economic recessions, and that these can be sustained for several years. And we also expect that the economic activity will be problematic in a lot of countries for a long period of time. And this translates to individual financial and personal problems. So you have job losses, reduced social status, housing instability, and relationship breakdowns. So increased mental health conditions such as depression, as well as drug and alcohol misuse, also are expected to have increased during the pandemic, which can affect, the rates of suicide. When they looked at the data coming out of Japan, they thought that the initial decrease in suicide rates was actually followed by an increase. So in Japan, suicides declined early in the pandemic, and they've actually had a subsequent increase of about 10% since then. What can we look out for? So the data seems to suggest that we can look at proximal markers of suicide risk, such as recent self-harm, incidence of new mental illness, might be a good way of looking at early warning signs. There's a big study out, it's an ongoing study, a rolling study, as in so many of the COVID-19 studies, and this is called the International COVID-19 Suicide Prevention Research Collaboration Study. And it's allowing for ongoing surveillance, especially in populations at higher risk. So what else have we gleaned from the data coming out of COVID-19? Well, one thing that they've looked at is, as I said, a lot of these studies are ongoing, and we're sort of extrapolating the studies or the data from the studies as they're, at certain data points. one of the studies is actually called the longitudinal UK data, and they looked at a period of April to October last year, and the data for this has just gotten published this month in Lancet Psychiatry. And they assessed mental health problems using what we call a general health questionnaire, or GHQ-12, and they looked at about 19,000, 20,000 people. About 12,000 of these people were over the age of 16. The majority were women. I think it's 58% were women. And they thought that the mean population mental health deteriorated at the onset of the pandemic, but they noted an improvement to some degree coming in July of 2020. So 1 in 9 individuals had deteriorated during the crises or had consistently poor mental health throughout the observation period. What they thought from their perspective was that risk factors were SARS-CoV-2, so actually suffering from the infection, having local lockdowns, financial difficulties were all predictors, as well as previous physical or mental health difficulties, living in deprived neighborhoods, and of ethnic minority. So I think just looking overall in terms of the data from what we've just gone through, what we've just reviewed, that regardless of the data source, it seems fairly consistent that there has been a decline in overall mental health or the experience people have had with their mental health during the pandemic. That being female, suffering from a disability, be it physical or a previous diagnosis of mental health, makes you more likely for you to have worsening mental health during the pandemic. Financial insecurity and being from an ethnic minority or frontline worker, all were risk factors, regardless of the studies that we looked at. And this was worse in children than it was in adults or even young adults. So the next thing we'd like to look at is what are the neuropsychiatric disorders associated with COVID-19. So I'm sure all of you might be aware of the term long COVID. So you will see on television, various discussions people will have, and they're talking about suffering from various disabilities several months down the line after being diagnosed with COVID. But what actually is long COVID? And there's actually no set definition. So the BMJ decided to try to come up with a definition. In last year, September, they held sort of like a mini conference webinar, as we have nowadays. And the definition they came up with was not recovering for several weeks or months following the start of symptoms that were suggestive of COVID, whether you were tested positive for COVID or not. So the thing that came out from the discussion is that COVID seems to be a multi-system disease and can occur sometimes after a mild or an acute illness. So as I mentioned, when I was going through the files on my computer, I realized how much our information had changed. We knew at the beginning of the pandemic that SARS-CoV was, or SARS-CoV-2 as it is, was related to SARS and MERS. And some of you might remember that I think it was a couple of years ago in Canada, there were some cases of SARS. So we've had some experience of it in the West, although SARS was predominantly a virus that affected the Orient. But from that experience, we knew that SARS is a neurotropic, could replicate in neurons, and that it had the potential of entering the brain via the receptors, which you might have heard of, the angiotensin converting enzyme 2 receptors, which you can be found in the olfactory bulb. So, the bulb that's responsible for smell. And the evidence coming out of China early on was that there was some element of cerebral inflammation, and neuroimaging was showing microbleeds in critically ill patients. And they thought that even though viral RNA, so the genetic code for the virus, is usually not found in the spinal fluid and brain samples, that there must be some element of this attacking the brain, because they found some antibodies in the cerebrospinal fluid. So we sort of had that picture, so it should be no surprise then that we expected to see what you'd expect to see in quite a few infections, that people will suffer from delirium. So delirium is an altered level of consciousness that can fluctuate with time. And indeed, this is the most common neuropsychiatric symptom that you can see in SARS-CoV. And it can be, in fact, the presenting feature in older adults and those who have a previous diagnosis of dementia. So it could be the thing that lets you know that they're actually unwell. It's more likely to occur in patients who've been in intensive care, but then again, we've said that mental health difficulties are more likely to be in that group as well. That cohort is probably more prone to have even PTSD as well. And it was known to affect people who have some cognitive and behavioral abnormalities prior to suffering from COVID. And it's been reported to occur in about 1/3 of patients after discharge. I think what was the most surprising thing from the studies that have come out so far is that though we expect this to be in older patients, it has been disproportionately found in younger patients in the studies that we've looked at. The most common presentation post-COVID from people who suffer from COVID is depression, can range from 11% to 40%, and anxiety can range from about 5% to 30%. And this is most common in the acute phase of the infection. The primary neurological symptoms that people tend to report are headaches, muscle aches, loss of smell, and change in their taste, which I'm sure you all know, because this is something you'll see on, the common questionnaires that you'll have about, do you have any of these symptoms? And if you do, please do not visit us. Sort of questionnaires that you get whenever you call up to book an appointment to go anywhere. Prevalence of major neurological disorders is most noticeable for stroke. So strokes, the result of blood clots, can be as much as 2.8%, and strokes due to bleeds can be about 0.5%. Seizure is quite low down on the list. As I mentioned, a lot of these studies are ongoing, and the study that's started here as soon as people realized that we had been suffering from these neurological disorders is something called the coronal nerve study. And this is a study that's been utilized by psychiatrists, general physicians, rehab physicians, and so on. And they're looking at COVID-19 associated problems. And what we found is there's an increased number of people who report psychosis, various mood disorders. There have been some reports of catatonia and encephalopathy as well. So we've covered quite a lot of information. As I mentioned about long COVID, I think I'll go and talk a little bit more about that. The WHO in Europe report about 1 in 10 incidence rate of long COVID 3 months post-COVID diagnosis. As I said, the numbers are quite surprising. A paper out in Lancet Psychiatry this year showed that 6 months after COVID-19 diagnosis, 33% of people report a neurological or psychiatric complication. So the first clinic that I think started looking at this has been UCLH. And they thought that 1/3 of, so that's University College London, sorry, and that's, they thought about 1/3 of people referred to their clinics were still unwell and largely able to work. more than half of those patients were never admitted to hospital for COVID-19 and apparently had a mild infection that had been persisting for weeks or months. The peak age tended to be people aging, age range between 35 and 49 years of age. It seems to suffer from people seem to have a characteristic pattern where they have a first wave, the typical symptoms we would describe of a cough and fever, and then this proceeds to second wave where they have something called dysautonomia. So dysautonomia is where things like your blood pressure will change dramatically, or you will have palpitations or a deranged heartbeat. And that will peak up to 2 months and then taper off. And then the third range of symptoms can include bizarre things like skin rashes, urticaria, muscle pain, and cognitive blunting or brain fog. The most common symptom people get referred for long COVID clinics is fatigue. Occurs in about 62% of patients who suffer from long COVID. Other symptoms, sleep disturbance, migraines, chest pains, new sensitivities to taste or smells. So it's quite a wide range. I think one article I read had said that there were 98 different symptoms that people had reported. And I think what should be understood is, I think the range of symptoms reported on patient-led forums is probably larger than what we're seeing in clinic. So there's a big patient-led research group called the Patient-Led Research Collaborative group, and they are a self-organized group of long COVID patients, and they do surveys among their patient group. Their findings are showing prognosis worse than what we see in clinics. So 50% of the patients that's seen at UCL who were not admitted to hospital initially have improved over the course of the year, and we expect that number to get better as time progresses. Whereas on the patient-led council collaborative research, they found 77% of their patients were still experiencing fatigue at 6 months. 72% were struggling with post-exertional malaise. 55% were suffering from cognitive dysfunction. And some of female patients, about 30% of female patients, were reporting problems with menstrual cycles. So I guess the question might be, where do we go from here? So before coming on today, I was listening to a talk by Professor Whitty, who is the Chief Medical Officer for the UK, and he was talking at our International Congress. And one of the things out of this pandemic, obviously, is getting vaccines in the population as a whole. I think the UK now, we probably have a vaccination rate in adults that's about 60-odd%, probably closer to 70% now. And it's really that once we have that, then we can sort of turn things around. In most of the country, things have gone relatively well. We have an upsurge now because of the Delta variant. I think the R number was about 1 for most of the country, with only the West Midlands and the Southwest, my area, having a rapid rise. I think when I looked at the data from today, Bristol had gone up from about 45 patients at one time in the pandemic to 191 per 100,000 now. In terms of the vaccines on the Delta variant, in case people had any questions about that, it's showing that 2 doses of Pfizer BioNTech was 96% after full inoculation. Oxford AstraZeneca was about 92 after full inoculation against the Delta variant. I do know that today there was some mention about a new Delta variant plus, which we don't have in the UK, but was identified in India. And that apparently is escaping monoclonal antibodies, which is one of the treatment regimens that's been used for COVID. But we don't have any reason to believe as of yet that will not respond to the vaccine. A separate study from Scotland has shown that the vaccination has cut Delta variant hospitalizations by about 70%. I think that is probably where we are, that once we get control of this with the vaccine, and we admit that there's probably going to be what a sort of a relapsing, remitting sort of approach where we'll get control and then you might get a variant and need to have boosters. So maybe in winter, things might get worse, and then things will get better again. So this will be a chronic problem that we will have to live with and deal with. All right. I wonder, that's a lot of information and I've probably bored most people. But I wonder if there were any questions or anything that I can, if you want me to expound on further.
Thank you. Thank you so much. That was really, really insightful. And I know that for a lot of us, it is quite scientific, but actually hearing the figures, no, that's, you know, we all know you're here. We know why we've come here and that's what we want to hear. And actually hearing the data when we're not used to perhaps hearing it to that level in the mainstream is fascinating. Sometimes perhaps not massively surprising. I guess we're all thinking that must be the way it's going, but to actually hear the data and the percentages like that, you know, it is quite shocking. So thank you so much for your time and for giving us such a comprehensive and interesting, fascinating, and not boring at all, by the way, as our members have said, talk. Thank you. We do have some questions coming through. I've had some from before from our members, and we also have some from today, and we had some just before we started as well. So I will start with, actually we've got a few here. We've got one from Tom, we've got a few that have come in, and I also see Karen's hand up. Shall we start with Karen, as you've got your hand up, and move to Tom?
Sure. Thank you very much, Mark. Good day to everyone. Mark, my question was, and sorry I'm not quite able to listen straight keenly. I'm planning a funeral at the same time. But I did not hear of there being problems in women with menstrual cycles. Have you heard anything about women who are actually going through menopause? Or was that just with younger women who are having menstrual cycles?
I didn't see anything specifically with regards to menopause per se, and I haven't heard that mentioned in any of the discussions or talks that I've attended, or in fact, in any of the clinical data. I mean, we do know that various stressors can affect people's menstrual cycles, and that can affect, that can affect how people might be experiencing, that difficult time in their life as well. So I wouldn't be surprising if there might be an element of that, but specifically with menopause, I haven't heard anything to be fair. I'm sorry to be so vague, but I'm happy to specifically look at that and get back to you. If you want to send it to Rita, I'll happily field that.
Great. Thank you, Karen. Thank you.
Thank you.
You're welcome.
Tom had a question for both Dr. Parmalall and Dr. Rose, and this is around human behavior, specific to the Caymanian behavior and the vaccine hesitancy. Tom says he believes that humans do not make choices purely from rationality, but from feelings. So how do we reach those who fear of being vaccinated, encourage them to do so, both to support themselves and the broader community? A good for all. So I wonder if, Mark, you want to take that, and also Tom, please feel free to pitch in and ask anything more specific about your question.
I was going to offer that to Joel, because it'll be interesting to hear the American perspective, because I think Joel is in is it North Carolina, I believe?
You are correct, sir.
Yes,
And it was wonderful hearing what you said today. I echo all of your sentiments, and it was very good to hear the data that you put forward. I was kind of talking with Rita behind the lines, talking about the long-term effects that is going to be very difficult to kind of estimate the overall impacts that this will have, especially from a psychological standpoint. I mean, it is such a domino effect like you described, you know, obviously from a socioeconomic standpoint, but also from mental health. But to get specifically with Tom's question about vaccinations, and it's hard to convince if you're not, I think if you're not really convinced at this point in time of the societal benefit of having vaccination, not even talking about from a personal level, I don't think you will be convinced at this point in time, especially in the United States. I think there are battle lines that have been drawn across Republican and Democrat, essentially. I mean, for the most part, that, you know, in a sense, refusal to see beyond the greater good and to say, well, from a political standpoint, I refuse to wear a mask, I refuse to be vaccinated, things like that. And I think there is an overall feeling that if I go along with a different viewpoint, that in a sense, I am, you know, going against my beliefs, or I am going against my neighbors, my friends, and there's an overall feeling of social exclusion, I would like to say, if you have a different viewpoint. And I think that can be dangerous on very many different levels, that I think we need to encourage people that it's okay to say no, right? And if you have personal feelings towards it, that you don't want to be vaccinated, that's fine. But at the same time, I think it's as physicians and as, you know, people that have different clinical backgrounds, I think it's important to provide people the information so that they can decide for themselves what is the best decision that they need to make. So I feel that pressuring people, I'm against that. I've always been, you know, I'm pro encouragement, but I feel pressuring people into making a decision is always a wrong thing to do. So I think we have a very slippery slope, especially from a government standpoint and things like that, to say, well, you know, to make it to, in a sense, punish people for not being vaccinated. I think that's wrong. Yes, we know that it's going to hamper our societies from an economical standpoint. The longer that things cannot open, we can just look at Cayman specifically at this point in time. But the benefit that we've seen so far in Cayman has been that we've been able to reduce the amount of cases, right? On the other hand, the tourism industry, other places are struggling because, you know, tourism isn't back yet, you know? So it's going to be, I think the right thing to do is provide the information. If people already have drawn their line and said, hey, you know, I have no plans on, you know, switching from my personal belief, I think that once you at least give them the information, let them decide. But you're not going to, I don't think it's the right thing to peer pressure someone to say, hey, you should do this, or to provide penalties for people who choose not to be vaccinated.
I think coming back to you know, the question about emotions, you know, heart ruling head, so to speak. I think there are some historical context that we probably can look at. For example, there is the experience where medicine, unfortunately, has been used by in some countries by the authorities for furthering their political aims, or I'm just thinking about cases, for example, in Eastern Europe in the past, where people were medicated and put in institutions to keep them out of the public eye. But one doesn't even have to look down that long road of history. Even recently in China, where they have had cases of the Uyghurs being detained and sterilized. So medicine has poor history in terms of, in some people's eyes, in terms of dealing with people, and it has been seen as to be open to abuse. So it's natural that a certain proportion, and usually the disadvantaged aspect of society, might feel very skeptical about some of the things coming out of medicine. I think in the US experience, there was the Tuskegee Airmen example, in which they gave, I think, the African-American airmen syphilis and refused them treatment. So you can imagine why a certain group would be very skeptical about medical science. But having said all that, I would hope that in this day and age where you have access to so much information and such a variety of sources, that you would be more than able to take the evidence and weigh it up and see the benefits for the vaccination, that it is there. So I think once you have an open mind, the information is there. And there are lots of professionals who will happily, I can't speak from the American experience because I imagine they charge you per visit and by the hour, but I'm sure you can see your GP, and your GP here will be more than happy to go through the information with you. So, while I do understand that people have an emotional sort of wall to some of the information, I would hope that having the information easily available to them and having professionals to help explain it to them might make it easier for them to come to a more rational decision.
Tom, you had something to add on that, I think.
Thanks. We can have different philosophies, Dr. Rose and I, but I'm not so much about pressuring people. However, the level of disinformation has got quite extreme. And the UK experience, I've lived in the UK for 4 years away from Cayman, is less polarized than the US. I think one of the things I've noted talking to so many people in Cayman in the last year and a half is that nobody's got sick in Cayman, right? So people don't have that first-hand experience. And actually, the most powerful thing about Dr. Paramlall's presentation was about the impact of long COVID. And I've seen that, and I know a lot of people who've got sick. I know people who've had family members die. The borough that, in fact, Rita and I live in mid-January, 1 in 10 people had current COVID. It was very, very high prevalence in the borough of Croydon at that point. And I think the vaccine hesitancy in Cayman is higher than it is in the UK in general. So it's just a no. We can't pressure people, but we are actually. We've got kind of let's be honest, a kind of a reverse racism going on in Cayman. Is that work permit holders are being told they have to do it if they want to live there. But we have freedom of choice depending on your passport. And if you want to travel, you are going to have both vaccines if you want to travel around the world pretty soon. So I think it might be the thing where there's a concept called the diffusion of innovation curve, that there are people who will lag and catch up with the general population, and that may happen. And I do agree with Dr. Rose that there is an economic impact on Cayman. Cayman won't be able to fully open their borders as long as chunks of the population just go, it's not for me. And it does impact the community. We can't pressure it. It's just, I was wondering if there are any thoughts around, the fact that the Cayman experience is different from the North Carolina experience, is different from the British experience. And perhaps, for me, when I talk to people, I go, look, I know lots of people who got sick from this. I know people who are actually suffering with long COVID months and months later in different ways. And the vaccines are not, all the disinformation, they're not experimental, they're fully tested. And they work. The level of hospital admissions in the UK is still very, very low among those vaccinated, even though the cases are spiking radically with the Delta variant. So nothing really to add on. I'm just wondering if anybody any thoughts around how we might be able to reach people, not as opposed to pressure them. That's all.
Yeah, I think I agree totally, Tom. I think it has to be personal. It has to be your personal experiences that you have had, and to pass that on and saying, hey, I've seen it personally, and I am honest. I mean, I tell people at the same time, I have seen people that have had both vaccines that still end up in the ICU. It's rare, but the overall dip that we've seen since the vaccinations came on board is exponential. It's not even in comparison. A few months ago, it was our hospital census. There's about 300 people in the hospital I work, and at one point in time, it was probably 20%, 20 to 30% COVID in our hospital, and this is a rural area of North Carolina. So now, I mean, it's one or two. I should say it's a little bit more than that, but a few people that are there. So, I mean, we've seen the impact that the vaccinations have made. And on the other end of not being vaccinated, it's kind of like a coin flip of how bad your symptoms were going to be. I know the data does not reflect that necessarily, but in terms of severity of the disease and what it turns out. But even if you're not looking at it from a physical health standpoint, I think the majority of us that are on this phone call realize, and that's why we were very appreciative, Dr. Parmalall, about the having to hear not just about, because we've heard so much about the physical issues, and yes, hearing about we really don't know how this is going to impact people from a mental health standpoint going forward. I mean, yeah, we have little inklings. I mean, we have good information now to show the short-term issues, but what about 3-4 years down the line, right? When you cannot perform at the same level as you were pre-COVID disease, or, and that impact that's going to make on your life, on your, not just your economic life, but your family life, your decisions of saying, oh, I can't cope with what is going on from a mental standpoint. I don't know what's going on. And you are using other things to deal with your issues. I mean, the level of abuse, spousal and child abuse, divorce rates, all of those different things. It's going to be hard to kind of put that on pen and paper and say, but I think we have some good data to at least show those things. Unfortunately, Tom, I think where we're lacking is not just on, I think for some people looking at data, they will take the data and run with it and say, okay, that makes sense. And there's some people that, that have to have personal encounters or know someone that has gone through it to make an impact. So I think for those of us who are on this call, now we have the information. If we can't necessarily articulate it in the way that Dr. Parmalall said, but we can do our part and say, hey, there is information out there. I could point you in the right direction. Go to your regular doctor, talk with them. And if not, there's I'm sure at this point in time, I guess it's going to be personal testimonials, people that you guys that are not living in Cayman at this point in time that can point out to personal encounters in your own cities. Like you said, Croydon was, one of the highest hit places and things like that, to pass that information on. So hopefully that will make the impact on someone else.
What I should mention about the vaccine information is, of course, with the, and it's probably less of a thing in the US because the US had their vaccines done via the recombinant, sort of the new versions of vaccines, with the mRNA being program for your body to make the spike protein and so on. So the Pfizer, BioNTech, and Moderna versions. Over here, maybe some of the resistance was because of the data coming out about thrombosis or infarcts due to our vaccine, the Oxford AstraZeneca. But even then, the data from that, I think, probably got skewed in the press. I mean, you'd have to, in every million, if I remember correctly, in every million cases of people getting a vaccine by AstraZeneca, you would have about one case of somebody having the thrombosis. So the risk of, it's 1 in 2 million, my mistake. So the risk is so minute, but I think people just fixated on it, and we have a very hard time and identifying risk with regards to those numbers. So that possibly may have been an issue. The other thing is, even though the vaccine is good, I think we probably still need to be aware that, for example, you have to have enough people having the vaccine for it to actually work. So, for example, in Israel, which had one of the highest vaccination rates of any of the larger countries, they are pushing for the vaccine to be given to over 16s because they've had a spike. I know that there's a case now in Cayman where somebody is apparently in intensive care unit who previously had both doses of vaccine. So just to give you an idea, in Israel, they had 10,000 daily cases of COVID. And it actually, because of their vaccine program, they actually dropped down to single digits earlier this month. And 55% of their 9.3 million citizens have had 2 of their doses. So it gives you the impression that the way out is actually to get vaccinated. But a third of the new cases this week have been vaccinated individuals who were re-exposed to the Delta variant. So I think, having the vaccine is quite important because it shows you a way out of the pandemic. And it also means that your chances of suffering from any severe morbidity is greatly reduced with the new variants that are coming out.
Interesting. A lot of interesting things coming out there and lots of questions coming. We are approaching the top of the hour. We sometimes will finish at 6, but in many cases when there's a lot of interesting topics going on, we do like to stay on. So those who do want to stay on, please do. We do have a few more questions if it's okay for both of our doctors now, if that's okay for you, a few more questions. So moving a little bit more generally for our audience and for our members, and your experience of being a clinical neuropsychologist here in the UK and getting to that high level position, what would your advice or comments or recommendations be for any of our younger medical students here who wanted to follow a path similar to yours, either in the UK or indeed the US?
All right, so to go, So I think probably I should be very clear. So there are 2 separate fields. There's something called neuropsychology. So for somebody interested in going to that field, they would have to do their bachelor's and then say a PhD, and then they'll have to do some clinical work on top of their postgraduate training, and that would be under the sort of direction of a psychologist, and then they'll have to get a job in a neuropsychology sort of unit, and they'll go through some further training and say like cognitive testing and things like this. Neuropsychiatry, which is what I am in the field that I work in rather, is a different field. So you have to do your degree in medicine. So you're a medical doctor first and foremost. After that, you do a residency, which is what they say residency in the States, but over here you have a longer period of postgraduate training. So we have a foundation year, which is 2 years of generalized training after medical school, at which time you get your full registration. And you go through the same foundation training that any other medical graduate would go through. You would go through various specialties. So you'd have some internal medicine. So for me, I did internal medicine, I did obs and gynae, I did orthopedics, pediatrics, I did A&E, I did high dependency unit medicine, and I did something else which escapes me at the moment. Obs and gynae, that's what it was. And then after that, you apply for your higher training or your core training. So I did mine in internal medicine, and I did that for 2 years. And then I went into psychiatry. Some people will go directly into psychiatry. So I did 3 years core training in psychiatry, which time you have to sit your examinations, postgraduate examinations, and then you go through a national interview, and you get ranked in the interviews. So everybody in the country, so it's a very fair process. Everybody in the country will get a ranking, and you apply to your post, and you have one interview that's held by the college representatives, and then you go into what's known as your higher training, and that process will be another about 4 years. So as you can see, it's quite a long road, and in that process you will have a post in neuropsychiatry if you're so fortunate. There are very few posts. I think in London we had one at UCL, you had one at the Maudsley, and so the Maudsley is King's and the Institute of Psychiatry, Neurosurgery and Neurology. And there was another one somewhere else. So we only had like 3 posts in London. There's one in Edinburgh, and I think there's one in the Midlands in Birmingham. So there are very few posts, so to get the post is rather difficult. And then while you go through that post, it's a 1 year, usually 1 year post that you'll have. I was lucky to be at a place called the Lishman. For those of you who follow the obituary columns, the Lishman is named after Alwyn Lishman, who passed away this year, and he's known as the father of neuropsychiatry in the country. He's the person who first authored the Lishman textbook of organic psychiatry. And they have a unit where all the hard cases in the country go. They specialize in what's known as functional neurological disorders, which includes things like dissociative seizures. So these are people who have seizures with no focus of epilepsy per se, or other neurological disorders that don't have identifiable cause. So, you know, one of the cases I remember is somebody who you know, wouldn't have movement of their limbs, and you work with them, they begin to move their limbs again. Or you have traumatic brain injuries, organic disorders, something like traumatic brain injuries or other acquired brain injuries. Sometimes people post-stroke or post-surgery, or people who have had severe falls or that sort of things. So that's sort of the trajectory. So what I recommend for a young Caymanian who is interested in getting into the field, I would say to start broad and actually think that this is something, you get a taste of various things. So you know that this is actually what you want to do, because once you sort of go down that road, the road becomes a bit narrow, and then, you know, it's something that you really should enjoy. You shouldn't sort of look down and say, that's where I want to end up, so to speak. I think be open to your medical training. And once you're in medical training, then you can taste various specialties and then make that decision. So I think my advice is not to think about that at the onset, but to think broad and then come to that, then sort of have that sort of come into your realm of experience.
Wow, that's really helpful. And I'm really glad you picked up on my deliberate, not deliberate mistake in neuropsychology and neuropsychiatry, because that was actually the next question. So there's where I slipped up. So you've answered it here now a little bit as well, because it's interesting. One of the questions we had before was the difference between neuropsychology and neuropsychiatry, which you've touched on now. But I think that's really good advice to say start broad. And we certainly pass this on and share. And it's just good to know that we have you there with that experience. Dr. Rose, while we have you on, is there anything you'd say from a US point of view?
I would say that, you know, the process is a little different, but I mean, it has a lot of similarities. It seems like a very long time with anyone kind of sitting back and saying, man, why would I make such a commitment to my life, to that amount of years of training? I'll just make it simple. It's a lot of years of training. Don't worry about all the years of training. Figure out if this is something that you are passionate about. Figure out if this is something that you absolutely can see yourself doing for the rest of your life. And if you feel that this is something that, you know, God put in your heart just, the process, we will help you get through each stage as it comes. And if you sometimes look at the overall long picture of it, it might seem impossible. So just taking it one step at a time. I've had many a day when I said, what in the world did I get myself into? And, why did I pursue what I did? But I realized that, if it hadn't been for all the steps and all the people that made it possible, along the way, that it would not have happened. But at the same time, I realized that it provided an opportunity like today to be able to help my own people, right? So at the time, you can't really see the long-term picture. You kind of, I'm sure Rita remembers when Dr. Tomlinson came in our 11th grade class and was talking about how cool it was to be a surgeon. And that's what got me interested. I was like, man, this guy is a hard worker. He had a lot of hard nights, as a trainee, and for whatever reason, that kind of interested me. I was like, man, that sounds like a lot of work and a challenge, right? So, that's what got me in the beginning. But what really sustained me and kept me going was, I really felt that this was something that God had put in my heart to pursue. And it was a long amount of time: undergraduate training, medical school training, residency, fellowship, all those different type of things. But you have to live your life each step of the way and understand that there's going to be challenges, just like any other profession. But I've had a colleague that was a fellow resident that of mine. We trained together. She was like the year above me. She went through all of those years, of training and finished and was working, and then decided that she wanted to be a vet. So now she is going back to veterinary school after being a surgeon, working as a surgeon, going through 20 years of training. And now she decided that she wanted to be a vet.
Wow.
So I'm just saying that, hey, do you, it's your life. It's a tremendous commitment and things like that. But I truly believe that this is what I'm supposed to be doing. And there are moments, I would say the downsides of being a surgeon is, being on call and having to go in when there's an emergency. But on the other end, you can see it in two ways, right? Thank God that I have the ability to help somebody who is in need during an emergency. And I am not by any stretch the most qualified person to talk about COVID or COVID-19, but honestly, I do feel qualified because of, Rita reminded me, I originally wanted to do law when I was in high school, right? And it was really going and working with Dr. Tomlinson that kind of changed my mind, So I thought growing up, Rita would have sworn she's like, he's going to be a lawyer and this and that, and the other. And, things change. So the bottom line is, find out what you're really passionate about and pursue that. And the other things they'll work their way out, as time goes along. Nothing is perfect. And there's many challenges. I'm sure all of us who are on this phone call, despite whatever field we're in, would give that similar advice that, being persistent, having faith, and I could tell you there are many a day, even today, the week that I'm on vacation right now, and the last week that I had at work was probably one of the hardest weeks I've had in my life. I've had patients that died. I've had, all those type of things that happen, and you kind of feel, what in the world not necessarily anything that I did personally, but things happen, and it causes you to kind of second guess your commitments and things like that. You sometimes get burnt out. I know my neuropsychiatrist can see the warning signs from the way I'm talking and things like that. But I mean, vacation, you have to make sure that you take time out for your family, take time out for yourself. And I think having Caymanian connection is an awesome thing. Honestly, and those are one of the other barriers that we sometimes neglect to talk about: isolation, right? I taught myself to compartmentalize. That's the only way that I dealt with homesickness. I left Cayman in 1998, right? I'm still here in the United States. I had no plans on staying in the US this long. It was always my plan on coming back to Cayman, and life took me in a totally different direction. And I am now here, and I'm more than likely will be permanently here. And it wasn't my idea. I always, and I always said, okay, I want to serve the people of Cayman, and I still am. It's just in a different way. So, bottom line is work as hard as you can, but understand that, life is more than your job title. And, hopefully it is something that you're truly passionate about, because that is what's going to take you through the hard times. So,
what I'd like to add is, although, was mentioned how long it is, and he gave some good advice to split up in time. I was sort of smiling when I saw Jennifer join the call earlier, and Kate, because I remember the time of Hurricane Ivan, and I thought how lucky the students are nowadays that they have these facilities of video conferencing and WhatsApp and so on to keep in touch. I used to call my mom and dad almost like daily. I actually used to call them daily, not almost daily. And I remember once I got a BT bill for almost £900 because during Ivan, there was no landline, so I'd have to call them the mobile phone. And I think my parents were a rock support, and I could not have done any of this without my mom and dad. And I really do remember those bills from BT, and think how lucky the kids are nowadays that they don't have anything like that. They could easily video chat their families and friends wherever in the world, and it does make it easier.
Amazing. So true, so true. Well, thank you both very much. I would like just to give the opportunity for any other burning questions. Rita, I think you may have glanced through and seen any questions, or if you have any yourself. But I would just like to say thank you both so much. This is amazing, absolutely amazing. And Tom's made a point about other doctors and nurses and those in the NHS, and we have been collecting a list of names of those over the world who've been working in the medical field, particularly over the last year, and that is growing, and we want to do something with everybody all together. That's the big mission, because it's incredible what you're doing, and I just want to, yes we do, Tom, I just want to say thank you so much. So huge round of applause, and thank you for your involvement. This means so much to all of our members. Thank you.
Thank you all.
Thank you.
Rita, would you like to add anything?
I just wanted to say that we are saving the information that is in the chat here. And if people still have a question, or you leave and you think, oh my goodness, I wanted to find this out and I didn't ask at the time, you know how to reach us, hello@caymanconnection.org. Or many of you are also on our chats, our WhatsApp chats. So do feel free to ask still. We are in touch with both Dr. Rose and Dr. Paramlall, so we can still ask the questions and get the answers for you. They actually might appreciate it, because they might have a little bit of time to do a bit of research if it's something that they don't have at their fingertips, which I highly doubt. But thank you. Thank you both so much.
And please share the word and let people know about Cayman Connection. The more people we can connect with, the more people we can help. It's as simple as that. And the more people that can help each other, that's what this is all about. So thank you so much, everybody. And we look forward to seeing you next time.
Thank you.
Bye.
Bye all.
Thank you.
Bye.